And a very good evening to you. I am Lisa Lord, and my special guest is psychiatrist and chairman of the National Mental Health Commission, Dr. Maisha Emmanuel. Dr. Emmanuel, thank you so much for joining us on your program.
Good evening. Thank you for having me.
You're most welcome. Now, I want to start very basic by dissecting what mental health is. Might seem very simple, but what is mental health?
Well, I'm glad you're starting there, Lisa, because so often when we say mental health, what we then proceed to do is talk about mental illness. So I think it's important that, people recognize mental health for just that, health. How do I maintain good mental health? So we speak about all the things that you would normally do to maintain good health, because your mind and your body are very much connected, So it's the same principles, things like getting good sleep, getting good exercise, eating well-balanced diets, and not so much concerns around taking multivitamins and vitamins and, supplements and so on. And so, downtime, time to relax, time to enjoy our hobbies, time to partake, whether it's religion or other spiritual types of activities, meeting up with our friends. All of those elements come together to maintain good mental health. And I really think if we focus there more, then there would be less need for people like myself and other mental health practitioners. And so I think for me, that's where mental health focus should be.
Now, in my introduction, I referred to you as the chairman of the National Mental Health Commission, but what is this commission? What is your role? When were you established, etc.?
Okay, so the National Mental Health Commission pretty much is an advisory body to the Minister of Health. We first started, meaning this current group of commissioners started only this year. We held our first meeting, and we have a 3-year term, and pretty much we have jumped right in from the get-go. One of our main areas of focus right now would be revamping or reviewing of the Mental Health Act. That act is quite old, dating back to the 1980s. And I think we really need to relook the act, thinking now not so much about inpatient care and admission into hospital, but how do we promote management within the community? And that's where the focus should be. We have to think about human rights. We have to think about the rights of people with disabilities, and we have to think about managing conditions in the least restrictive environment. So we're trying to go away from hospital, and talk about community care and having persons with illnesses remain at home as much as possible. So it's a completely revamped way of looking at how we care and treat to mental illnesses. So part of the Commission's role is to do that revision. In fact, last week we just finished 3 days of consultation together with a consultant from PAHO, where we started the process of reviewing the Act. So we've met with, professional organizations. One of the most enlightening meetings we had was with people with lived experiences. So persons with mental health diagnoses, as well as the caregivers. And some of the things they said they would like to see put into the new act, we've taken on board that. So we've met with a number of different stakeholders, and that process will continue as we get further in depth into reviewing the act. The act is one thing. The other things the Commission has been involved in, members of the Commission, we are currently working with the Ministry of Health, looking at developing a mental health hotline. And that pretty much came out of the ministry as a response to all the number of suicides we've had recently. And in fact, one of the things we looked at in doing an analysis of those situations was the access to care. What happens at 2 o'clock in the morning, meaning after hours? It's not a 9 to 5 thing. When everybody's at home or on a weekend, how can I access care if I am feeling depressed, if I am having suicidal thoughts? What do I do? How can I reach out to my friends, my relatives, whomever? Okay, so coming out of that, we've determined that, the ministry has determined that the mental health hotline is vitally important. And so we have been involved in bringing all the elements together so that we can have a hotline so as to improve access to care after hours.
two things you said there that I do want to revisit a little later in the program: suicides and the Mental Health Act. However, to understand mental health, I want to look at some of the conditions, some of the more popular conditions, starting with anxiety disorders. The average person, I think, might be anxious about something.
Right.
We tend to worry, especially us mothers tend to worry quite a bit. Let's look at anxiety disorders.
I'm glad you started there, because there's a misconception out there that if you're going to see the psychiatrist, you must be a quote unquote mad person. Right. And I want people to recognize the overwhelming majority of people who present to a mental health practitioner would either be anxious or depressed. Psychotic symptoms, those make up the minority of people who present to us. Okay? So if you're going to talk about anxiety, now it is normal to feel anxious about things that you are not accustomed to. So, an exam coming up, you don't know what's on the paper, so of course you're going to get anxious. But there's a usefulness to that. It then forces you to go and study.
Yes.
Okay, so anxiety in that way is protective. It becomes pathological when the amount you are worrying, or how severe your worry is to such a degree that you then cannot function. Okay, so if you're so anxious to the point where you're getting panic attacks, you can't make it out of bed, you are working, you have to leave and go home, or for some people they're driving and with a panic attack they have to pull off to the side of the road. Clearly that is not adaptive. That's not helping you in any way. So that's when we start making diagnoses around anxiety disorders, and there are many. Okay, so for example, you may hear somebody talk about generalized anxiety disorder, where the person worries about any and everything. They say to you, I'm just a worrier. It's the person who says, I'm just a worrier. As long as I can remember, even when I was in school, I used to worry about, getting up, what's going to happen when I'm at school, what's going to happen if the bus doesn't come, what if the rain falls, what if the teacher doesn't like me, any and everything. So that really is about a lifelong pattern of worrying. And it's easy to understand how something like that can become very debilitating. There are other conditions like panic disorders where, interestingly, people would say, well, I don't know what I'm worrying about. Nothing is bothering me. All of a sudden, I am woken out of my sleep, for example. My chest is pounding. I'm sweating. I can't think straight. I feel as if pins and needles or hot and cold sensations running up and down my body. Often, people feel as if they're having a panic attack. It is very frightening for the individual to have that experience. And so if it's one thing that would get people to the doctor is the experience of a panic attack. But that's another anxiety disorder, okay? There are multiple other things like, phobias, social anxiety, where people don't like speaking in public, which is another common one. So there are myriad of reasons or ways in which people can present with anxiety.
You mentioned depression, and depression is interesting because sometimes you would hear somebody when they have a quiet moment say, I'm depressed, but that person carries the biggest smile that you will ever see.
Right. And so we make a distinction between somebody, you had a bad day, you say, oh, I'm so low, I'm sad, or you had a disagreement with somebody and you feel down in the moment. And again, emotions, feeling sad, that's normal. Again, like we said with anxiety, it becomes a pathological thing where your mood is so low or it's so intense or it's going on for so long that you're unable to function. And you would hear in psychiatry, we come back a lot to function. Function. Are you able to do the things that you would typically do day to day? So with clinical depression, not just I'm feeling down today because of X thing. With a clinical depression, or what we call a major depressive disorder, you need a couple of weeks of feeling this way in addition to a number of other things. So the doctor would ask you, or the psychologist, whomever you're seeing, yes, about your mood being low. We want to know if you've lost interest in things you used to do. We want to talk about your sleep disturbances. Often people do not sleep well. So they will say, well, either I can't fall asleep or I fall asleep, but then I wake up and I can't get back to sleep. So I'm tossing and turning, and then the next day I'm exhausted because I have not slept well. There are changes in your appetite. Often people do not eat, and they lose a lot of weight. Their difficulties concentrating, and that shows up as poor memory. So many times I see somebody who's 35 years old and you're thinking, do I have dementia? I'm like, no, you're not having dementia. What it is that you're not focusing on what you're doing. And if you cannot focus, you can't retain information, and therefore you can't recall it. And that's why your memory feels as if you're losing your memory. Other things, people, of course, people depressed experience suicidal ideations. They may ruminate about things and feel guilty or worthless. And then other people start to notice, so-and-so not moving right, they're slowing down. And when you ask them a question, they're taking long, almost like they have to pull from the recesses of their brain to understand what it is you're saying. So the point I'm making is, in diagnosing clinical depression, there are several factors we look at, not just somebody saying, I'm feeling down today because X thing has happened. So it's multifactorial.
We hear a lot of people talking about somebody being bipolar because they have split personalities, but break down what it means to be bipolar.
Right. So people often mix up psychiatric terms. Bipolar has nothing to do with split personality. Split personality refers to dissociative identity disorder, which is a very rare condition, what people would call multiple personalities.
Yes.
Right. That's nothing to do with bipolar. With a bipolar condition, as the word says, bi, so two poles, highs and lows, okay? The lows are like what I described before, like somebody who is depressed. But the highs can take the form of what we either say is hypomanic. So if you think of it, if this is your normal mood and you have fluctuations, good things happen, you feel good. Somebody who's hypomanic, mood is a bit more elevated than what you would consider to be what is the typical thing for them. Whereas somebody who's manic, their mood is all the way up here. Right, so we make a distinction then between bipolar 2 and bipolar 1, which is getting a little bit more technical, which is something you would go through with your practitioner if you were to have that diagnosis. The point is, bipolar means highs and lows. And with the highs, people feel, well, I'm feeling great. What is the problem? The problem with the feeling great is that it doesn't end there. There are other behaviors associated with the feeling great that may land the person in trouble. So you may become irritable. You may start snapping at your coworkers or your boss. You're talking a lot, going from one thing to the next, sometimes not really making a lot of sense with what you're saying. You're getting involved in a lot of activities and not quite finishing them. So you can imagine the problems that will create at work.
Yeah.
You've asked to do 1, 2, 3, you've taken on 10 and none of them are done. And then you stay awake all night, so you're not resting very well, and you can then easily become exhausted. As things escalate without management, you may then become grandiose, start talking about, I know I have all the answers to all the world's problems, and then you become delusional. So it's not just about feeling happy and all is well in the world. Sometimes people end up doing things like taking out loans, spending a lot of money, ending up in a lot of debt that they cannot repay. So these are problematic things. And so that's why if somebody's exhibiting symptoms like that, they really need to get assistance. And so it's not a laughing matter. Very often I see people in the beginning, people say, oh, this person just happy-go-lucky. We're not talking about happy-go-lucky people. From what I just described, these are problematic behaviors because it's over the top, it is not productive, and it can land the person into a lot of trouble.
That sounds like a hard condition to diagnose because, as you said, there are people with over-the-top personalities.
Yes. Right, but the difference, remember what I said about function. You can be over the top. I know lots of people who are very chatty, friendly, outgoing, life of the party. That is not what bipolar is. When you get to the point where you are not functioning. So yes, you could be happy-go-lucky, but it cannot be that you're so happy-go-lucky that you're not going to work, or you're at work, but you're doing very disruptive things, or you're now becoming delusional in your capacity to do everything and then not doing anything. And getting into, the problematic behaviors I was talking about in terms of spending and loans and, sexual indiscriminate sexual activity with lots of different people, that is clearly problematic. And so we make a distinction between, what are manic type symptoms and what are just, people's typical personality.
Schizophrenia.
Okay. So schizophrenia is one of the psychotic disorders. It is not one thing, meaning if I have schizophrenia and somebody else has it, it will not necessarily look the same way. And that therein lies part of the issue, because people say, well, he's going to work very good. I don't know, he seems normal to me. The diagnosis of schizophrenia requires a number of elements. So people may have what we call hallucinations. Typically, it's that people hear people who are not present. It is not what the public would typically say, voices in your head. By definition, a true hallucination is external to your head. All right? So we have hallucinations. You may believe things that are not true, what we call delusions. Your behavior may become disorganized. Your thinking may become disorganized. You may have what we call catatonic symptoms, where you don't interact, you don't talk very much, there's little facial expression, you'd have nothing, your emotions are very blunted, very little interaction with the external world. So from what I'm describing, you can see there's a wide range for somebody who is withdrawn, not very interactive, all the way to the other end of the spectrum. It's someone who is hallucinating and expressing a lot of unusual beliefs, and anywhere in between there. And so there's no way to just say, right, this person has schizophrenia. It's the diagnosis that takes time to come to a conclusion about it, because it's going to be different from one person to the next. And that's the crucial thing. So point being, it's not something to just like an armchair diagnosis and start calling terms and labeling people and getting it wrong. Because when you say somebody has schizophrenia, you are saying that they have this chronic condition. And all that comes with that in terms of management and what that is going to mean 5 years down the road, 10 years down the road. So it's not something to jump into lightly by just, reading, Dr. Google. You go on Google and put in some symptoms and come up with a conclusion, and you go with that. That's not the way any of it should be done in terms of diagnoses.
Post-traumatic stress disorder.
Okay, so that's one of the conditions that comes about having experienced, witnessed, or it happening to you, some type of traumatic event through which you felt quite threatened, either with some severe injury or death. So typically, people who have been involved in MVAs, motor vehicle accidents, people held up at gunpoint or knife point, people who have been sexually assaulted, those types of traumatic events. And what tends to happen is that the person re-experiences the event. So months later, and herein again, we make a distinction about the timeline, because we understand that it is normal to react in a certain way when something traumatic has happened to you. So if you're in an accident and somebody has died, unfortunately, or whatever it is, or you've been injured, of course you're going to have bad memories and unable to sleep and get anxious and so on in the days and weeks following the accident. However, if those symptoms persist beyond that period of time and they again function, it affects your function to the point where you cannot get back into a car, or you are terrified. I have patients who are terrified of being on the highway because of the experiences they've had, or if an area that reminds them of where this incident took place. So people re-experience, people have nightmares, people have what we call increased startle. So the door slam and very exaggerated response because you are so on edge and so anxious. There are changes in your mood as well. People have difficulties sleeping. All right, so there are certain sets of symptoms that we look for in terms of just anxiety, mood, re-experiencing, and avoidance. So you don't want to pass the area, you don't want to talk about it, even the emotions surrounding it, you don't want to experience, and so you avoid any type of memory or trigger. You don't, anything to do with whatever the incident was. And so PTSD can be chronic, oftentimes. And the other thing that I have found is that it is also associated with people with chronic pain, for example. So you've had some accident or injury, and together with the PTSD, you're having chronic pain from the condition. So the two things together now increases your illness burden, as you would imagine, and makes it that much more difficult to manage.
From my research, eating disorders are also categorized as mental health conditions. A lot of women in particular tend to suffer with body image issues, men as well. But we know sometimes diet and exercise simply don't help, and people then have issues with consuming food. They don't want to eat. They either eat and then they bring it back up, bulimia. So are you seeing eating disorders in your practice?
Yes. And can I start off this discussion around eating disorders by saying this? In Barbados, we have a greeting where you get very fat. And can I say that people need to recognize how traumatizing, I will use the word traumatizing, that can be for the recipient of the comment. You may not say it meaning to be mean, but it is quite mean for the person who is hearing that you're referring to start off a greeting in that way. Because too often that comment can be the genesis of
be triggering
the eating disorder, as we have seen. You know, without meaning to be horrible to the person, that is exactly what happens. So people then start to feel, and you know, with social media and the expectations of women usually, and that's why we see it, this is scientific fact, is typically women, young women, unfortunately, and I say unfortunately because I think it is not right that we are teaching our young ladies, teenagers and 20-somethings that, you know, there's a way that they're supposed to look, and if it's not exactly like that and they're not perfect, then there's a problem. Okay? So I think we need to check ourselves and recognize what we're doing when we make these comments to other people. More and more, because I've now been in mental health for just over 20 years. And when I first started, compared to what is happening now, more and more we're seeing people presenting with anorexia, which is in which the person restricts what their intake. And we've had cases of having to have people in hospital to ensure that they're able to eat in a way that is healthy. We don't often think about what we're doing when we are restricting our food and the impact it has on our heart and your other organs, as well as the impact. Yes, the weight is there, the loss of weight is there, but the impact it has on our reproductive system as well. So there are many areas that we have to look at when someone is going through an anorexic condition. The other condition, the other eating disorder would be bulimia, where there's the opposite, where people eat more than they should over a short period of time and then purging behaviors. So you either make yourself throw up or you use laxatives or diuretics. And again, it's around people making comments. Sometimes the triggers could be around people making comments about weight, either gain or loss. So we really have to be mindful of what we're doing when we say these things. And, you know, just to make the point as well, that treating these conditions can be very difficult, right? Because there's that whole mindset change that has to occur because we are raised in a certain way in the Caribbean, right? And we have our own cultural issues around food and what looks good and what doesn't look good. And everybody's trying to navigate that and fit into those molds. And so that's why it can become so difficult.
So it's a culture shift. Stop telling people that they've gained weight.
Exactly. Or just stop commenting about weight, whether it's gained or lost, because you don't know what somebody's circumstances are. That is their business, you know. Let them deal with it and not promote a problem.
And this is outside of eating disorders, but you mentioned reproduction just now, and I know that's another trigger as well. That can trigger some women into depression. Well, Dr. Emmanuel, when you gonna have a baby for your husband?
Well, yes, exactly. And it, you know, there's a magic number that people have decided. You know, if by X age you either well, either you have to be married, or if not, you have to have a partner, and if not, well, you have to have a child, and if not, so when you have the first one, then when is the second one, and on and on. It never stops, right? It can feel like that. You've never done enough of what you're supposed to do as a female or as a whomever. You just never enough. And, I want us to understand we are enough. We're good enough. We've done enough with whatever we have accomplished. And there should not be this pressure to get married or be in a relationship or have a child or have another child or have a third. We are enough.
Yeah.
We could have none if that's what we've chosen to do.
Right.
That is our personal choice. And that's what I would have to say about that.
And in a lot of instances as well, some women have been trying for years or have had miscarriages for years.
Exactly. People often struggle with fertility.
Yeah.
Sometimes it's related to the woman. Sometimes it's related to the man. The point is, it is a personal struggle. And if somebody wants you involved, they will come and tell you. What we don't need to do is to keep pressuring the person and saying, what happening, when this can happen, how come it hasn't happened yet, and on and on and on. And that goes for family too, because family can be some of the main culprits in that pressure being applied to the individual. So we just have to be mindful. You know what it comes down to? Just be kind to people.
And minding your business.
Well, yes, and minding your business. But the same way you have to think, how would I feel were I in this situation if somebody was coming at me with those types of comments and questions? And you can feel ridiculed, right? So we have to be kind to each other.
All right, well, we do need to take a break. Dr. Emmanuel, stay with us. Still a lot more to discuss here on One-on-One.
Hi everyone, I'm Dr. Danielle Reed Melillo and I'm a general physician. And today we're going to talk about exercise for obesity prevention. Exercise is important for your overall cardiovascular health and it's excellent for obesity and overweight prevention. I'd like you to aim for at least 4 days of exercise per week, and this exercise should consist of resistance training and aerobic exercise. You also want to have an exercise that you enjoy, and this will help you to stay consistent. Some examples of exercise could be walking your dog, walking with friends, swimming, or exercising at the gym with your trainer or with a group of friends. Exercise is also great for mental health and for stress relief.
Welcome back as we continue our discussion with psychiatrist and chairman of the National Mental Health Commission, Dr. Maisha Emmanuel. Dr. Emmanuel, in the first half, we would have looked at several mental health conditions or illnesses. We would have looked at what mental health is, what the commission is doing. Re-addiction now. What is the biggest addiction in Barbados? Is it gambling? Is it use of illegal versus legal drugs?
So the biggest or the most frequent condition people present with is with alcohol and what we call alcohol use disorder. As you know, alcohol is legal, and so that clearly will contribute to how accessible it is, and so that would be the condition we see. We also see people who present with marijuana use disorders. The difficulty there, so I know there's a big debate worldwide about whether or not there's a connection between psychosis and marijuana. Yes. Over the years, we've looked at the trends in terms of, through research I'm talking about here, and more we've seen the evidence that there is a connection between people developing psychosis having used marijuana. This, though, typically occurs, or I should say mostly, for people who are genetically predisposed. So first, our early use of marijuana, the quantity you use, the frequency, and the potency of it all will play into that development of psychosis. And as I said, the presence of a genetic predisposition. And by that, I mean, if you look around and see people in your family who have had other psychotic conditions, it means that your risk of developing psychosis, having used marijuana, is elevated compared to the rest of the population. So more and more, there's evidence out there around the two associations between marijuana use and psychosis. The other thing that we found too is that not only in terms of the development of psychosis, but the relapse of conditions, things like schizophrenia and other psychotic conditions. We do know that there's an acute intoxication that can occur with marijuana use that can present with psychotic symptoms. But when I say schizophrenia, I'm talking about the prolonged, enduring type of condition, not just the acute intoxication. So from a public health point of view, we have to consider, because you know now the move is towards decriminalization and a kind of loosening up of the rules and regulations around marijuana use, we have to consider, well, as a society, what does that mean for us? Are we prepared then to manage the young people who are going to be presenting increasingly with psychotic symptoms, for the ones who are vulnerable in that way? And so that's a discussion that is, quite, and it's going on in the public. I think it's an important discussion for us to have, because we have to decide as a society what is it that we are prepared to cope with, really. As we decide on the one hand what we're going to do in terms of the laws around marijuana possession and use, and what that means on the other hand for the persons developing psychotic symptoms.
In the first half, you would have briefly touched on suicides. September is recognized as Suicide Prevention Month. Now, here in Barbados, as you would have also touched on, we would have seen an increase in the number of suicides, at least within the last 5 years or so. Mm-hmm. How concerned are you at this increase?
Right. So you said increase in the last 5 years, but more recently than that, we've seen a number of people who would have died by suicide in a relatively short period of time. Now, Barbados traditionally has had one of the lowest suicide rates compared to the rest of the world. In recent months, with the increase that we have seen, we have taken a serious look as to what are the risk factors, so that putting things in place to address these conditions, okay? One of the things that we recognize is the whole business around, as I was saying earlier, the access to care, and that's how the mental health hotline came up. But access can be in different ways as well, not just the hotline. It seems that people are not aware that in every polyclinic in the country, there is a psychiatrist every week, and in some polyclinics, twice a week. So in other words, there are people out there, and there are ways in which you can go and access care in the polyclinic system, because I know a lot of people are not happy about going to or may not be happy about going to the psychiatric hospital because of the stigma involved. And equally, they're not happy coming to the QEH because of, again, stigma around mental health, although we do also have a service. So here you have in the communities around the island, where in the polyclinic system, you can access care in that way. And so, we really have to, I think a big part of managing suicides is about public education. What do I look for?
What do you look for?
Right. So I often, when we talk to patients and their relatives, we say changes in presentation, changes in the person's behavior. Somebody who was typically chatty and outgoing, who is now more withdrawn, reserved, maybe seemingly reflecting on life. What's the purpose of me being here? I've not accomplished anything. So you have to listen. That's the first thing. Observe and listen. What is this person saying? Okay, what are these changes? What is the content of what they're talking to you about? People may present, with feeling very anxious, You may find that they're irritable more so than usual. The things that they're saying are not in keeping in what they would, how they would normally speak. They may start preparing, giving away things, leave the job, just doing things in a manner that is not usual for that person. And you have to pay attention to the signs, all the things we spoke earlier about in terms of signs and symptoms of different conditions, but also specifically when it comes to suicide, is about listening to what the person has to say. And the other thing is creating an environment where the person knows that they can come to you. And that starts with what we say about mental health. So if people know, these mad people, I can't talk to them, I don't want to hear anything about it, then the person is not going to come to talk to you. They're not going to magically say, oh, I'm feeling down now, so, I'm going to speak to my friend, when all along you've been clear in the way you've been talking about mental illness that you're not the person that they can come to. So you want to create that environment where the person feels comfortable, that they can come and confide in you. And then having gotten their confidence, work with the person. So it's not just about, I can't cope with this, I don't know what to do, I'm not the person for this. You want to be there, be that support, and encourage that person to seek help if you feel that you're not in a position where you know what to do.
But Dr. Emmanuel, sometimes when you talk to family and friends, they say there were no signs, nothing about that individual had changed.
Yeah, and that is obviously a problem, because then if you're not seeing because what I'm talking about would be the obvious things, but to your point, there are times when, in spite of your best intentions and your as much as you may be looking and observing and talking, you're not seeing what it is I am talking about. And so yes, it makes it very hard in those circumstances. But remember, the point is to have that environment, or I should say create that environment, and keep the dialogue and the talking going, so that hopefully the person is going to be, at the point where they feel, I really need that person to come and walk with me through this, that they have that person there. You can only try and keep trying.
Now, we in the media at some points have been cautioned about reporting on suicides. In some instances, we had stopped, I think, for a couple of weeks reporting on suicides. However, the media, we have an obligation to report on unnatural deaths.
Yeah.
Suicides are unnatural deaths.
Right.
What is your position on that?
Well, my personal position, I think, I've often asked, what is the point of reporting on a suicide? Meaning, what is the benefit? And I have personally held the position that unless you are going to report it in a way that it is helpful to the public, I do not see why the public needs to know that Mr. John Brown did X, Y, Z, and all the details that I've seen reported to get in the story. Having said that, I do understand, as you said, it's an unnatural death.
Yes.
And there may be value in the public knowing about it. For me, the value is in what are the signs to look for, just like what we've been talking about. And the other important bit is, how do I access care? Where do I go to if I'm feeling that way? And that's the part I've not seen consistently done in the media reports. So yes,
consistently, because we have been doing it.
Yes, I would say that, right? I'm not saying everybody's getting it wrong, but it needs to be consistent, because it may be that one person who heard that one story, who said, and at the end of it you heard, and if you're being affected in this way, this is the way that you access help. And that is why it has to be consistent. So whether it's print media or, the television, it needs to be consistent. And so I know that there's been a, WHO, for example, has a whole document on the best ways in which to report on suicide so as to prevent contagion. That's the term we use to mean, because what it is? It is the vulnerable person. It's not the person who has no, depression or no psychosis and they're not thinking about harming themselves. It is the person who has already started thinking about suicide, who then listens to that story, gets all the details about what was done, and oh yes, I know so and so, and but if that person could do it, well, I could do it too, and then goes on and completes the act. And that is the difficulty. The report should be in such a way that you talk about hope and management, and that things can and will get better with intervention. And all of that needs to be part of the story, not just the details around what has happened to this particular person.
And in many instances, that is a part of the story.
We want it in all instances.
But we never get everything right.
Correct.
So initially you started by saying, from a personal
Yes.
perspective, you said you don't think we should report on them. But then you ended by saying, if we have to,
Yes.
you ensure that you tell persons where they can
Yes.
go to seek help if
Yeah.
they're feeling or having suicidal thoughts.
Yeah. And so that's why my view on it from the point of view of not reporting has changed to add in that part. So if you're going to report, make it make sense for the public or for that person out there who's struggling, not just about the details about who did what and when it happened. That is the
I
point.
take your point, but we in the media have an obligation to report on
Fair enough.
such. So we will agree to
add in that part.
add in that
Yes.
part. Yes.
Fabulous.
Very well. Now, as a psychiatrist, you diagnose and treat mental health conditions. One of the ways you do that is through medication. There is a belief amongst many that these same medications actually make the problems worse.
Yes. And we in psychiatry, we've done that to ourselves. To be fair, because when medications first came out 60, 70 years ago, the side effects looked worse than the actual positive effects of the drug. So people would say, oh, I look like a zombie. And that's the side effects of especially the antipsychotic medication, where you lose, and the reason why you look like a zombie, as people would say, is that some of the side effects, you lose the natural facial expression. So as you talk, day-to-day life, you talk to people smile, they frown, they may wrinkle their brow. That goes away with some of the older drugs. The natural arm swing when you walk, that goes away. The pace of walking slows down. So when you look at the person, you say, but this looks worse than when the person came for the treatment.
Yeah.
And so that was
you don't see
many
a lot
years
of
ago.
that, no.
Exactly.
Yes.
So that's where I'm getting
Yes.
at. Because nowadays we now have newer therapies that you do not get those side effects. You get other things, which is another topic for discussion. But that changing in the facial expression and the arm swing and all of that, the newer drugs do not cause those things. And so over time, we have seen an improvement in terms of the side effects of those medications, so that more and more now we should see less and less people presenting in that way who've been on long-term antipsychotic medication.
Speaking about being on long-term antipsychotic medication, that also creates another issue where this person now is dependent on that medication, and that kind of causes an addiction.
Right. So we make a distinction between what is an addiction, or whether it's physiological or psychological, versus requiring medication to manage a condition. So in the same way, we wouldn't say somebody is dependent on insulin for their diabetes, meaning that they have to have it or they go into withdrawal. That's not addiction. It is that you're using the insulin to manage the blood sugar. So in a similar way, we use medications, whether it's be antidepressants or anxiolytics for anxiety or antipsychotics for psychotic conditions, to manage a condition. The person is not physiologically or psychologically dependent or addicted to these medications. They use the medications to manage the condition. And the easiest way for me is to use the example I just used about you use, blood pressure medication to manage your blood pressure, but you don't say that you're addicted to your blood pressure medication. You use, certain medications for lupus, but you're not addicted to those medications. So in a similar way, you use medications to control or manage mental health conditions, but you're not addicted. Having said all of that, there are things that you can be addicted to. Prescribed medication.
To get there. Yes. Mm-hmm.
So things like diazepam, or Valium, or alprazolam. Everybody knows Xanax, or lorazepam, Lorivan. Those things are drugs that you become addicted to. Those medications are indicated for the short term. Can I say it again? Short term, 2 to 4 weeks. That is not what happens in practice. We see people months, years later on those medications, and that's not how they're supposed to be used. That is why addiction comes up. So that you take it for, say, sleep.
Yes.
And you realize after a few weeks, oh, it's not working anymore. It's helping me. It was helping me very good, but no, it's not working. So let me take a little bit more. And then that works for a little bit, and then it stops working. So then you take a little bit more. And before you know it, you're on 8 milligrams of lorazepam, and you're still not sleeping properly. So what was working in the beginning is no longer useful. And in fact, with some of those, that class of drug, it's called a benzodiazepine, you then start getting the opposite effect. So instead of helping you to sleep, it's now keeping you awake. But you have so conditioned yourself that you need this tablet to sleep, so you get yourself in a whole cycle that you cannot break. So the best thing is to avoid all of that in terms of use it as prescribed for a short period of time to manage whatever it is that you're experiencing, and not to use it for weeks and months, and in some cases years on end, because that's the problematic use at that point.
Now that we're on the topic of drugs, I know that the commission is also looking at some of the basic drugs used in psychiatry.
Right. So one of the goals we've set for ourselves is to come up with well, I wouldn't say directory, but we want to have a list of all the conditions based on international standards that we should have on island. Okay, because there are certain things that we should have all the time. Yeah. And so that's the list that we're coming up with. One of our colleagues, Dr. Gibbs, who is not on the commission, but she has accepted our invitation to do that for us. And so we want to look at basic conditions. I think in Barbados, we're very fortunate in that for the management of anxiety conditions and depression, we have a really good range of medication. We're talking about medication, so I'm just going to focus on that. And when it comes to antipsychotic medications, again, we have a good range. Where we need to plug in terms of increase what we have would be around, say, management of ADHD. Right now, we only have one primary drug that we use, the management of alcohol use disorders. So it's those types of things we want to put together and make a justification for why these things are important, so that the population has options available to them. So it's great what we have, but I think we need to expand that and get up to our international standards so that we are able to offer a full range of treatments for everybody.
In the first half, you touched on the Mental Health Act of 1980, which is an outdated piece of legislation, and one of your concerns surrounds the issue of admissions.
Yes.
That is an issue for a lot of people who are saying, I had called this place asking for this person to be institutionalized. I can't get them into that institution.
Yeah. I think it comes down to this, and I keep saying this about access. How do I access the services that I need? And one of the things we are discussing, and we've started, as I said, in our early discussions around the act, would be building out community services. Many years ago, we used to have a very vibrant community mental health service where people will go into the homes, and you still have that going on now, but it needs to be expanded. Right? So we need multiple people who are able to do that role, and not just have one or two people in a catchment area. Because think of it, that person is working, well, technically all the time. You know what I mean? So what we need are really well-organized teams. So it shouldn't just be the nurse and the doctor in the catchment area. You need teams, and whether we have them based at the polyclinic and then they go out into the communities, the point is we need to have more people out there and decentralize the care. So people shouldn't have to come into the QEH only or the psychiatric hospital only. We need to build out those teams in the community, and that'd be a big part of the review that we are doing now, to put those things in place so that we get the care where you need it, and not that you have to come down into the hospital setting to access care.
And I had a conversation with Mr. Kimar Safri from the Barbados Alliance to End Homelessness a few weeks ago, and he indicated that sometimes it is very hard to get these persons into facilities where they can get treatment, because you do know that they have mental health conditions.
Sure.
You would call and you would say, I have some person out here acting weirdly. Can you come? And it doesn't work like that. He's saying that sometimes they have to attack somebody for then something to happen.
Which is unfortunate, because in psychiatry, we deal with the business about risk and assessing risk, which means you don't have to wait, or you shouldn't wait until harm comes to somebody before you respond. But again, the system that is in place works, but it doesn't work all of the time. And so that's why this review of the act is so important, because we need to see where the problem areas are and fill those gaps. And that's what this is about. How do we get enough people out there in the community that can see and respond to what is needed in terms of people needing the care and getting the help that they need?
No, in many cases where persons are depressed or have some other type of disorder, there's a history behind that outside of the triggers. We are a small society. A lot of persons have concerns regarding confidentiality, and me coming to a psychologist or a psychiatrist and saying, I want to talk to somebody, but can I trust you?
Right. Mental health practitioner, any mental health practitioner, let me not say mental, any health practitioner is bound legally and ethically to keeping a person's confidence. There are exceptions to those rules, and it is clear what those exceptions are. So I often explain the exceptions are, if you say to me, I have abused a child, whether it be physically, sexually, or otherwise, I cannot just say, oh, okay, then carry on smartly. I have to report that.
Yes.
Okay? If somebody says, if a court says, you have to tell me what this person has said, I can't tell the judge, well, indeed not, I'm not doing that. I have to disclose. So, and the other exception would be if your risk is high, risk of suicide or your risk of homicide is high. So not just any risk. People come and say to me about the way they've been feeling in terms of having thoughts of hurting themselves, wanting to disappear, all of that. I don't necessarily say anything about that. But if on my assessment, I think, if this person leaves here and goes home, they will do something to themselves. I cannot just say, oh, well, I can't say anything because you tell me don't say anything. That would be a moment when I would have to break confidence. The point I'm making is, outside of those parameters that I just spoke about, we keep information confidential. There are lots of people who come and, talk about things going on in society that we may know about, and I say nothing. One of the things we've always been know to do is, you don't say yes or no, I don't know, because even that in itself is breaking confidence. So you just say nothing, okay? That's how it's supposed to work. Now, I do understand that does not happen like that all of the time, but we have to keep aiming for what is the ideal thing and recognize that overwhelmingly your information is kept in confidence, except under those conditions that I just explained.
Anyone that might be listening to this program or watching it, and they want to reach out to a psychiatrist or a psychologist or maybe a family member, when is it time to come see you?
That can be any time. Because I'm not going to tell people sit down and wait until X, Y, and Z happens. I think the fact that the thought crossed your mind, I am struggling, reach out to somebody and take it the next step. If you talk to your family member that you trust, or somebody at work that you trust, or your priest or whomever, talk to that person, and two of you can walk through that process and decide, well, this is too much for me. I think you need to go the next step. And so you reach out to your general practitioner, you reach out to your doctors in the polyclinic, you can reach out to the psychiatrist in the polyclinic, the psychiatric hospital, QEH. There are several points of entry. Oftentimes you just need to work out which one works best for you and get the help that you deserve. Nobody if it's nothing else people take from this talk, nobody should sit in silence and suffer for conditions that are treatable. And that is the main thing. You do not have to feel this way. You don't have to continue feeling this way. You don't have to continue suffering in this way. There is help available out there.
That's a wonderful point on which to end. Dr. Emmanuel, thank you so much for sitting and chatting with us this evening.
You're most welcome. Thank you for having me again.
You are most welcome as well. That was Dr. Maisha Emmanuel, the chairman of the National Mental Health Commission and psychiatrist. I am Lisa Lord. Thank you so much for watching One on One. Do have yourself a wonderful evening.